Good evening, everyone. Welcome. Thanks so much for joining us for the virtual UMiami Health Talk titled The Mind and Memory, Cognitive Aging, Brain Health, and Alzheimer's Challenges. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by the University of Miami Health System Department of Psychiatry and Behavioral Sciences Memory Disorders Clinic. Our clinic provides compassionate care for individuals facing a wide variety of challenges and conditions related to memory. The center draws on the knowledge and experience of a multidisciplinary team of professionals at one of the country's leading academic medical centers. Because memory problems can have many causes, the team takes a holistic approach to assessing, diagnosing, treating, and managing each individual. Knowing that every patient is different, our doctors are actively involved in leading-edge clinical trials that may offer new options to their patients. To learn more about UHealth's Memory Disorder Clinic, let's visit umiamihealth.org/psychiatry. Call 305-243-0214 to schedule a consultation. You're going to have that information up on the screen again, so don't worry. You will have it repeated and we'll give it to you again. So tonight we're breaking some news. The University of Miami has announced a $30 million investment to significantly boost research and innovation in basic science, with a particular focus on the fields of neuroscience and aging, aiming to advance understanding and potential treatments for age-related neurodegenerative diseases. This investment will even establish a new computational biology program within the Miller School of Medicine to foster collaborations across different university departments. To learn more, please scan the QR code on the screen or please visit our Inventum blog. Tonight, we're going to hear from one of the premier memory disorders experts, Dr. Elizabeth Crocco, who will discuss the latest advances in this field affecting so many families. At the end of the presentation, there's going to be a Q&A session. Now, that's a unique opportunity for you to ask direct questions of our experts, so take advantage. Just use the Q&A feature at the bottom of your Zoom screen. Take a moment to locate it, enter your questions, and we'll prep them for Dr. Crocco. Now, let's please welcome Dr. Elizabeth Crocco. She's a clinical professor and chief of geriatric psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of Miami Miller School of Medicine. As medical director of the Center for Cognitive Neuroscience and Aging, she oversees the coordination of the Memory Disorder Clinic, all interdisciplinary teaching and community outreach for Alzheimer's disease and other related dementias in South Florida and the Florida Keys. As a clinician scientist serving the multi-ethnic population in South Florida has been central to her research to address health disparities and to improve access to geriatric services for underserved populations. She also has a significant role in both developing and testing novel neuropsychological and functional measures developed to detect mild cognitive impairment leading to Alzheimer's dementia. And she's a primary investigator in multiple clinical trials aimed at modifying its symptoms and disease pathology. Dr. Crocco is the Geriatric Psychiatry Training Director at Jackson Memorial Hospital, overseeing the training and supervision of geriatric psychiatry fellows, psychiatry residents, medical students, among all other healthcare professionals in this field. There's so much more to say about her, but please welcome Dr. Elizabeth Crocco to our screen, who's going to give you a lot of important information tonight. So stay tuned and then stay with us for our Q&A session. Dr. Crocco, you're ready to share your screen and go to it.
Thank you so much, Ileana, for that absolutely beautiful and lovely introduction. So the title of my talk, as Ileana said, is Mind and Memory, Cognitive Aging, Brain Health, and Alzheimer's Challenges. So for the next hour, we're going to focus on healthy brain aging, brain health, improving our brain health, and some of the challenges in diagnosing, treating, and managing Alzheimer's disease. I'm going to talk to you all for about 30 minutes, and we're going to review my slides. And then after that, Ileana and I are going to go through a number of your questions, because I think that's often the best part of this hour, to answer the questions that you have specifically. So let's begin. So this first slide is talking about a changing population. This is a popular slide that I often give to young physicians that I'm teaching by showing them, unless you're going to be a pediatrician or a specialist like a sports medicine doctor working with the Miami Marlins, most of your patients are older. Older patients we're an aging population. By 2030, 1 in every 5 residents will be at retirement age. Persons 85 plus will triple. Globally, the older population is showing a dramatic increase. People are living longer. But the question for all of us should be, how do we want to spend those extra 20, 25, maybe even 30 years? It all depends on good health. So we want to age gracefully and we want to age well to retain our cognition, our physical health, our functionality, and our independence. That is really the goal for all of us. And brain health is part of that formula. Optimizing brain health is really an essential part of successful aging. We need to reduce the risk as we age of common cognitive disorders, such as Alzheimer's disease and other related types of dementias that cause neurodegeneration and that we see in people over 65. And we refer to that as ADRD. And they are as important to us in medicine, for your primary care physician, and for your other physicians. They are as important as reducing, let's say, hypertension to lower your risk for cardiovascular disease. We also want to know what are the things to do to reduce the risk of Alzheimer's and other types of dementias. So first, we talk about some of the common ADRD or Alzheimer's disease and related dementia risk factors. We're going to mention a little bit about dietary intervention, eating healthy and eating in a way that doesn't put on weight. We're going to talk about vascular risk factors, because usually we have a saying that what's good for your heart is usually good for your head. So any of those recommendations that your physician makes to prevent heart disease and to have a good, healthy heart is also, and also to prevent stroke, is also good in preventing Alzheimer's disease. We're going to briefly mention limiting alcohol use, which could be a toxin that can add to that risk, and also the ability to recognize and treat people who have clinical depression so that they also can reduce their risk. Some of the predictors of risk for Alzheimer's disease include the duration and the severity of cognitive symptoms. Many of us, starting at age 50, definitely over 65, can talk about senior moments when we have some forgetfulness and cognitive changes that may not be the same things happening to us as they did when we were 25. But typically, it's the duration, when it's frequent, when it happens a lot, and when it's severe. This often has us more concerned that this is a form of cognitive impairment that may lead to or be part of dementia or Alzheimer's disease. We also talked about vascular risk factors, high blood pressure, hypertension, having diabetes, having high lipids or hyperlipidemia or high cholesterol, having actively smoking tobacco or a sedentary lifestyle are also risk factors for Alzheimer's and related dementias. Having a history of head trauma, right? So not just one-time head trauma. So for example, if you're in a motor vehicle accident and you have a significant head trauma, but often even repeated head traumas for people, for example, who play American football and have repeated traumas to the head can be a risk factor. Genetic risk factors, we call it the ApoE4, having that carrier status. You inherit one gene from your mother, one gene from your father. That can put you at a higher risk to develop late onset Alzheimer's disease after 65. Psychiatric illness, untreated depression and recurrent depression and anxiety can be a risk factor. And any one of the combination of these factors adds to that risk. This is a slide that looks at some of the blood biomarkers we have that talk to us about genetic risk. We've known about the ApoE gene as a genetic risk from the time I was still a resident in New York around 1993. And what this shows, if you can look at this little chart, it shows that you inherit one gene from your mother, one gene from your father, and if you inherit an E2 from your mother, E2 your father, you're less likely to get Alzheimer's disease. But if you move over to the other part of this chart where it says E4, inheriting one E4 from your mother, one E4 from your father, it puts you much more likely to be at risk for Alzheimer's disease. And this little graph down below, this little picture, shows you that it can be upward as of a 10-time greater risk. And so these genetic risks are important to us and something that we can look at in patients' bloods. So I've given you some information about risk factors, but the million-dollar question is, what can I do? If I'm 40, if I'm 50, if I'm 60, if I'm 70 years old, Dr. Crocco, I can't change some of those factors. I can't change the fact that I'm aging. I can't change the fact that I inherited a genetic risk from my mother and father. What can I do? Well, the good news is now researchers have established that there's probably about a 35% chance of that these risks of developing Alzheimer's disease have the potential to be modifiable. And most of them are lifestyle behaviors that can really make a difference even as you get older into your middle and senior years, that can make a difference in preventing the onset of Alzheimer's and related dementias. This is a list. Again, this is only a half-hour talk and I have a lot to cover, so I'm going to try and go through this quickly. What can you do? Number one on the list that I always promote is the ability to move and exercise. This is so important as we age. It's important for our brain health. Many patients ask me, what kind of things can I do online? What kind of games can I play? Well, and oftentimes I say, well, playing games and doing things online and keeping your brain active is good. But what's even more important is physical activity. Physical activity, including cardiovascular things like walking or swimming or riding a bicycle, and lifting weights or doing strength training. In addition, focusing on balance. These are really the things that tell us a lot about healthy brain aging and the ability to move and get out of a chair and get out of bed when we're 85 years old, is our ability, is our need to exercise. Eating a healthy diet. There are many diets out there, but the focus is really on eating more fruits and vegetables and whole foods rather than eating refined things or things that are very high in fat, such as red meats and whatnot. Stopping smoking. We now have a lot of ways to stop smoking and a lot of aids and treatments to help people. Controlling diabetes and making sure that there's tight control on your sugars. Treating anxiety and depression and being able to recognize it in you or your loved ones and making sure they get to a doctor. Lowering cholesterol and lipids. Social engagement is a huge factor. Many times patients will say to me, since the pandemic, I have not gotten out of the house. I haven't really done very much. And this is not good for cognition and healthy brain aging. Even just socially engaging with others is a protective factor. Getting a hearing test. We now know that starting in middle age, if you have a hearing impairment, it increases your risk of Alzheimer's and related dementia. So I do recommend for everyone a hearing exam to see if you need a hearing device or aid. You know, I joked with somebody who attended one of my lectures. He was 65, and there are many people afraid to wear hearing aids because it makes them look old. And he showed me his hearing aid was a little tiny thing that he put into his ear. And he said, nobody can see that. I said, I didn't even see that. So a hearing exam, because if you need a hearing aid, it's important. And then, of course, as we mentioned, to control hypertension. The early detection of individuals who are at risk and are starting to have symptoms. This is an absolute priority here in the United States and globally, and is really the focus of many of us in the field and researchers, because the earlier we can detect somebody having problems that will lead to Alzheimer's or related dementia, the more we can do to help you. So this slide talks about cognitive aging. This is always a question that multiple people ask. How do I know that this is just part of normal aging because things do slow down cognitively? And how do I know if this is really a problem that I need help, that it may be that I'm having the beginning stages of a disease like Alzheimer's disease? Well, what is cognitive aging? There's a general slowing of information process, and we have a decrease in complex attentional tasks. We can't divide our attention as well as we used to. So we have more difficulty multitasking. We can only focus on one thing at a time. We have trouble listening sometimes to someone, especially when we're distracted. So our selective attention may be declined. And our working capacity memory, our ability to calculate something in a busy restaurant, may be difficult. We also may have harder a time with our memory to gain new information and learn new things. And we may have difficulty retrieving information that is already there. And those are those senior moments that people talk, I can't come up with the name of that actor or the name of that movie. Now, this sounds like a lot. Wow, we really slow down as we age. But the key factor to this is that even though these things are normal as we age, right? My 25-year-old son, he's going to learn faster than me. My 20-year-old, he can divide his attention better than me. But the reality is that these symptoms tend to be not that frequent and not that intense, and certainly should not interfere with your day-to-day life and functioning. So they're benign and they're mild. So then there is this concept called mild cognitive impairment, MCI. This is a concept for people who don't have, it's not normal aging. They don't have dementia, where they have a cognitive impairment and an illness that leads to their ability to function, that leads to them not being able to function at home. This is kind of like an in-between state where the person is having cognitive problems and complains of memory problems, or their family says, hey, I think he's having some memory problems. But they function normally. They just have normal aging. They may have memory, if you test them memory-wise, they have difficulties, but they're not demented and they function normally, right? So this is kind of a conundrum. Well, how do we differentiate these people from people who have normal aging? Well, this is where the expert physician comes in. And that is why when you start to have, or your family starts to notice a change that seems to be a little more frequent, you should come in for an evaluation at a place like the University of Miami Memory Disorder Center. So these patients who have this mild cognitive impairment, or MCI, they may do worse than normal subjects in some cognitive testing. The primary distinction is usually memory. And cognitive assessments, when we do evaluate you, can consist of a memory evaluation, a language evaluation, looking at your visual spatial skills, and your executive functioning, which is your ability to plan out things. So it's important for us to know whether or not you're suffering from just subjective, normal, healthy aging, or if you have this mild cognitive impairment. Now, not everybody who has mild cognitive impairment goes on to develop Alzheimer's or related dementias. Sometimes it's reversible. This is why it's so important not to ignore those signs, but to come to the physician. Because the treatment goal is to try to reverse this memory deficit and delay any sort of progression that may evolve into a dementia due to Alzheimer's and other illnesses, right? So what about dementia? So dementia, we now have a new term for this in psychiatry and in medicine. We call it a major neurocognitive disorder. It's not normal to have this. This is where cognitive dysfunction occurs, but other symptoms can occur. These patients can have neurological symptoms like have trouble walking. They can have difficulty with weakness. They can have vision problems. They can also have psychiatric symptoms such as anger, irritability, agitation, depression. And these are the patients that really become dependent on others because of these impairments and can't take care of themselves, typically because of their cognitive problems. You see this most commonly in people over 65, and it's usually a neurological type illness that degenerates or gets worse over time. You can get a major neurocognitive disorder when you're younger from having, let's say, a head trauma, but it's usually much more common in older people and that degeneration. There are many different causes. A lot of people get confused. Well, is dementia the same thing as Alzheimer's disease? No. Dementia is just the syndrome. Alzheimer's is the most common cause, especially over 65. But there are other illnesses that you can commonly see dementia in elderly patients. And I have a little pretty picture here, talks about, see, at Alzheimer's at 50 to 75%. But you could have vascular disease that leads to dementia or strokes. You can have something called Lewy body dementia, which is a form of Parkinson's disease that can lead to dementia. And then there's another type called frontotemporal lobar degeneration. And those four diseases are the most common illnesses that you will see causing a type of dementia that progresses over time, that's neurological, that that occurs in people over 65 or older people. So the criteria for dementia includes that the cognitive problem is so severe that it really interferes with the person's ability to be independent and to do things and to work and to function, pay your bills, to cook a meal, to go shopping, right? And it represents a decline from a previous level of function. And it's not explained by something like a psychiatric illness, which sometimes when people suffer from severe psychiatric illness, they can become dysfunctional, right? And it's not due to a physical cause. And it's usually the way when you come to a memory disorder clinic, the way we diagnose this is we ask you a lot of questions about your history. We ask your loved ones, your family members questions, and then we test you to see if there's an impairment. So typically also, when you go and see a memory disorder specialist, we order some tests. The first thing we order is typically some cognitive testing to see how bad the impairment is, and we compare those tests to what we see in populations of what should be normal for someone your age, if you're 65 or 70 or 80. We also will often order neuroimaging, such as an MRI of the brain, to make sure that you don't have other things causing it, such as having a tumor or a stroke or too much fluid in the brain. There's also blood work and often an EEG that is ordered. But I want to, I've been talking for about 20 minutes, and I really want to focus now on some of the newer stuff we know about specifically Alzheimer's disease. The other illnesses I mentioned, such as Lewy body disease and vascular disease, there's a lot of stuff going on there, and there are some biomarkers evolving for Lewy body disease. But I want to focus mostly on the most common one today, since we only have a half hour, which is Alzheimer's disease. Brain imaging of a protein called beta amyloid. It's a protein in your body that's abnormal. it forms these plaques, these proteins, they misfold, they don't fold properly, and they form in your brain in between the nerve cells. That is the hallmark feature of Alzheimer's disease, that abnormal protein called beta amyloid. And we can see that through brain imaging, we now have something, it's called a PET scan, a positron emission tomography. And this very pretty colored picture here shows that, and it's the cut through a brain, that we can actually measure amyloid in the brain. That is the hallmark feature, and that is the key diagnostic way that we diagnosed Alzheimer's disease. It's FDA indicated for Alzheimer's disease, and it is a brain scan. And it usually starts with a infusion. So you have an infusion is placed into you through an IV, and it will attach they're called radio tracers that will attach to if you have amyloid in your brain, and then we take an X-ray of it, and that's what we can see whether it lights up positive or negative. This is, again, the gold standard now that we have for diagnosing people with Alzheimer's disease. It is expensive. Okay, Medicare is paying for it more and more because we now have some more disease modifying treatment. So oftentimes, if your loved one has cognitive problems, the doctor might order a scan like this to look for Alzheimer's disease, specifically if the doctor thinks this is the condition, in order to give treatments for you that are specific for Alzheimer's disease. Now, there are other abnormal proteins that we see in the brain due to Alzheimer's disease, including something called tau or phosphorylated tau. And we can measure these things, both the beta amyloid and tau, also through the PET scan, as well as doing a spinal tap or doing a lumbar puncture or spinal tap, looking at the cerebrospinal fluids. We don't typically do that commonly because it's intrusive and it's invasive. But when it comes to the PET scans, we also have tau that is FDA indicated scan for Alzheimer's disease. That's not done that commonly clinically because it's not 100% specific for Alzheimer's disease, but the tau scan is more useful in measuring the progression of the disease and when it gets worse. We now have, over the last 18 months to 2 years, we now have blood-based or plasma biomarkers. By taking someone's blood, we can measure some of these abnormal proteins now. And they're called, all of these things are called biomarkers that suggest that you have the disease. And they're also useful because we can track and manage the disease by following these numbers. They're not 100% diagnostic, but they're getting better and better. And so nowadays, we have plasma biomarkers for amyloid, tau and phosphorylated tau, and other plasma biomarkers. And the million-dollar question that I think all of you will have in your mind is, who should get these blood tests now that Medicare is paying for them? Well, this isn't really a test. It's not like a PSA, which is a prostate-specific antigen. I use this as an example, which is a biomarker for problems in a men's prostate. So, for example, it may go elevated when somebody has cancer. And so we use that as a screening exam. We don't use these tests as screening. So if you're over 65, even if you have a family history of Alzheimer's disease, if you're cognitively no problem and you're functioning great, and you don't think there's any problems with your cognition, we don't recommend these tests, right? Because just because these tests may signify you at a higher risk for Alzheimer's disease, those tests can't tell you whether or not you're definitely going to get it, and they can't tell you when you're going to get it. So we don't think this is reasonable. These are more reserved for older adults who are starting to have that mild cognitive impairment and early dementia. In the memory disorder clinic at the University of Miami and within the CNSA, which is the Center for Cognitive Neuroscience, where I'm the medical director, we actually have cognitive stress tests and biomarkers where we can test you cognitively in a brief test, and we stress your brain in a way that if you have some abnormalities, we can pick it up from a basic test. This is called the LASI, the Lowenstein-Aceveda scales for semantic interference in learning, and we have computerized it to make it more easy and accessible. We're trying to get this available to other physicians, including primary care doctors, to make it easier to screen people who are starting to have complaints of cognition that's worse than that expected, to rule in and out Alzheimer's disease at an early phase. So we're at 6:30, but I want to go through this quickly. I am a trained and board certified geriatric psychiatrist. One of the reasons I am very successful in the clinic is not just because I can diagnose Alzheimer's disease and I know a lot about it and I know a lot about the treatments, but it's also because I recognize the emotional and behavioral symptoms that patients with dementia and Alzheimer's disease get is 90% of the time. And this is often the thing that is most debilitating and most upsetting to both the patient and the care provider or the loved one. And they can run the gamut from aggression, depression, anxiety, disinhibition, and sleep disturbances, as well as psychosis. And these are symptoms that oftentimes we can really help. And the consequences of having these symptoms are not good, because not only are they disabling and upsetting to the patient and their loved ones, but they cause a more rapid decline cognitively, functionally, and you're more likely to die quicker if you have these symptoms and become hospitalized and be placed in a nursing home. So I like to focus. We focus a lot on helping patients and helping them with all their medical stuff, making sure their hypertension, their diabetes, that everything's being taken care of. But I do want to mention that the ability to take care of their neuropsychiatric and behavioral symptoms is also very, very important. This is just a listing that talks about certain medicines that we want to avoid in the elderly. I believe that family members and patients should be their own advocates. And so part of what I do is try to teach people, whether you're going to see a new physician or you have to go to the emergency room or be in the hospital, you are your greatest advocate. And so I like to share this list of medicines that are medicines you want to try to avoid in the elderly because they can contribute to cognitive loss, especially if somebody already has MCI or dementia. And they include medicines like Benadryl, diphenhydramine, or oxybutynin that is often used for urinary incontinence, any kind of sedative or sleep medicines that's thought of as a sedative, and also pain medicines that are opiates. When it comes to behavioral intervention, helping people who have behavioral problems, it's important that you understand that always a pill is not always the answer. Sometimes when you come to an expert like me in a memory disorder clinic, we do non-pharmacologic intervention and education first. And these simple techniques can often change it and make the patient much happier and alleviate a lot of these symptoms. So why do we do behavior? Why don't I just write a prescription for these patients first and foremost? Well, I do use medications, but medications can only do so much. And sometimes they don't work. Sometimes they cause a lot of side effects, and sometimes they stop working. Whereas behavioral treatments are more individualized to you and to the patient and the loved one, and it empowers people. So I want to skip ahead to talk about the new FDA-approved drugs that target amyloid and whether or not they're effective. But before I do that, I just want to mention that for many years, we have other treatments that manage the symptoms. They don't cure it, but they help to manage some of the cognitive symptoms and improve them for a short period of time. And you may have heard of some of these medicines. One is called a cholinesterase inhibitor, like donepezil, rivastigmine, and galantamine. And the other is called an NMDA antagonist, memantine. These are still very useful drugs. They don't cure the disease, but they can starve off the decline and improve somewhat. So there are 2 new FDA-approved drugs for the treatment of Alzheimer's disease. They are lecanemab and donanemab. Okay, they've been around for about 2 years. There was an original drug that was first FDA indicated that's not available anymore. These are the 2 drugs that are available right now. They're called monoclonal antibodies. They're antibodies that attack primarily amyloid and beta amyloid in the brain. Okay, they are only indicated in patients who have mild cognitive impairment or mild dementia. So these are not indicated for people who have Alzheimer's disease, that the disease is more moderate or severe. They're only indicated in people who have very mild symptoms. And in order to start this treatment, you usually have to do an amyloid PET scan. Now, the good news, even though it's a very expensive exam, but the good news is that Medicare is covering the cost of this now, which has really been revolutionary in the last year or two, because before that it would cost thousands of dollars and most people could only get it through research. So this scan is now available, particularly if you want to start this treatment. You must prove that the person has amyloid in the brain. These are not medications on pill form. They are infusion treatments. So a lot of people, they get a little taken aback when they hear that. You have to dedicate 18 months to infusion treatments. One of the drugs, lecanemab, is twice a month, and donanemab is once a month. And you have to go to an infusion center to receive these treatments. And it does modify the disease. It shrinks the amyloid a good 50% in most cases, and in some cases it reduces the amyloid to nil. It does it does not cure Alzheimer's, nor does it reverse it. It slows, this is a degenerative disease, it slows the progression of the disease, slows it down, and it slows it down significantly, but not significantly enough that you're going to see major changes in your loved one, or the patient's going to experience major changes. And I think that's really important for you to hear from an expert, because we have to make sure you understand the expectation here. This is the case where we do that ApoE genotyping. And the reason we do the genotyping when we're going to give the treatment is because those patients that are E4 carriers, that are at those higher risk to have inherited that Alzheimer's disease or have that genetic biomarker, they're more likely to have adverse reactions to the drug. So that's important information for the doctor to know. And those adverse reactions can include infusion reactions from having an IV in and having a drug go into your bloodstream, because a lot of the times that can cause inflammation in your body, it can cause a rash, it can cause a lot of discomfort, hot flashes, and other symptoms. It also, because of the shrinkage and the elimination of this beta amyloid, it can cause ARIA. They're called amyloid-related imaging abnormalities, because it's changing your brain. It can cause small hemorrhages or bleeding, as well as brain swelling in small area. Now, the vast majority of patients who develop these side effects, they're extremely minor and they don't even preclude you from continuing treatment. But in some cases, these symptoms can be severe. So I wanted to just stop here by saying, this is our memory disorder clinic at the University of Miami. We've been funded by the state for close to 30 years, and we offer a lot of services. Not only do we offer state-of-the-art comprehensive evaluations, but we also help in the management and support of loved ones and individually. This is our team from the CNSA, including Dr. Rosie Curiel and Dr. David Lowenstein, my partners in crime in Alzheimer's disease. And these are just some of my wonderful women in the clinic that work with me. I want to point out Sophia Ramirez, who is my overall manager and coordinator, as well as Amaya Venus, who is my absolutely wonderful advanced practice registered nurse, who is superb. Thank you.
Thank you, Dr. Crocco, and thank you for putting up your team members. I'm sure they're glowing with pride tonight. And by the way, for the audience, we're going to put up the numbers again toward the end of our conversation so that you can see the phone number and the emails and all of that, because a lot of the Q&A box is lighting up with people saying, how do I contact the clinic and how do I get in and all of that. But let's kick off the Q&A session with this thought. You said something that is mind-blowing. You said by the year 2030, we're going to have that 85 people who are 85 years and older will triple. So does that say that the correlation is that Alzheimer's and cognitive impairment will triple in the next 6 years as well, possibly because of the aging population?
Yeah, there's positives and negative thoughts about this. Obviously, the negative thought is that we're going to have an epidemic or a pandemic of Alzheimer's disease because age is the greatest risk factor. By the time we reach the age of 80 here in the population, a large, significant, some would say 25% of people have Alzheimer's and related dementia after 80, 85. So yes, that's going to add. On the other hand, there is some evidence, particularly in some Scandinavian countries and elsewhere, that if we look at that 35% of lifestyle changes that we can make, that this may really starve off some of these cases even as we age. And that's why it's one of my biggest focus. I work with so many people over 60, 65, and I just don't focus on medication and treatment and biomarkers. I do enjoy focusing on these lifestyle changes and giving suggestions because these can really make a difference.
No question about it. We have many questions that have either been pre-submitted or the Q&A box is still lighting up and pinging. But let me take this in reverse now, since your last statements were what has gotten a lot of attention, and that is the infusions to reduce the amyloid plaque. I mean, wow, we're here, we're in the future to the point where we can start. And you said something, we're not reversing the disease, we're slowing it down. But again, let's reiterate that to the audience who's saying, can I have that? Who qualifies? Who should get that? Who is the profile?
Yeah, so I'm going to repeat this carefully. So this is how it works, okay? This is why, and I can say this 10 times, when you have a loved one, because oftentimes it's the family that's the first one that notices, or you yourself or the person themselves, you really start to say, you know, I'm concerned that my memory, my cognition, there's something not right. There's something not right. And I think it's, you know, I feel like I'm very forgetful. My daughter thinks my husband thinks I'm very forgetful. You need to be evaluated, period. The best case scenario is we tell you you're fine, right? You need to be evaluated, because if you let it go on, you may not qualify for these treatments. That's
Right.
the take-home message today, is if you're having issues, get evaluated. It could be a false alarm, right? And what the doctor will do is the evaluation. We get a history, we do the cognitive testing, we do the blood biomarkers, and then if we think it's Alzheimer's disease and that you're a good candidate, we may do the PET scan, right? To see, is this somebody who's a good candidate for these disease modifying treatment? So I think that's pretty clear, Liana, right?
So basically you get to that point and you're now diagnosed, this is the patient that qualifies for that infusion.
Yes.
Okay.
But again, sometimes I said that the reason you got to get in early is because I've known some patients that they want the treatment, but their dementia has progressed to a point where it's too severe, because if it's more moderate, they're not going to qualify for this treatment. It really has to be people who are cognitively having just mild symptoms that are going to qualify for that treatment.
Until we get to the next, hopefully 10 years from now, where perhaps there will be a greater portion of these patients who would qualify. So now let's get to the other $1 million question. What is considered normal forgetfulness and normal, what we all say all the time, senior moments, and what is not?
It's real, for me, it's always about severity and frequency, right? So when you're having lots and lots of senior moments and lots of forgetfulness and lots of difficulty processing things, and it's very, very frequent, maybe every day, that's a concern, right? Those things usually are not that common. And when it's interfering with your ability to function, that's really the biggest one, when you're really struggling with different things. And when it's more, and it's also when people around you notice. When people around you notice, there's a reason why in a memory disorder clinic, we always want a family member to accompany you, because we need to have a corroborative person who observes you, and we ask them questions. Are you seeing what the patient is seeing? Do you also think that this person is having cognitive problems? Because sometimes they pick those things up. So it's how severe, frequent, and does it interfere with your life? That's when you come in and get an evaluation.
And let's pinpoint some of these, Dr. Crocco. For instance, can't find a word, can't find a normal word to say that desk or that chair.
Yes.
Lost driving, perhaps, things like that that are more severe than like, where did I leave my keys or my cell phone?
Yeah, so I'll give you a couple of examples, right? So I had a patient who 3 times he kept going to his son's old house, even though the son had moved to a new place a year ago. That was a red flag, right?
Okay.
Right? Because he just couldn't get it, even though he kept reminded. So that one was a big one.
Let's keep going because we have so many questions.
Sure.
6:47 and we only
No
have an hour.
problem.
You and I know we need 2 hours for this kind of thing. We have hundreds of people here just hanging on every word, and you're such an incredible communicator that it really helps to put people's minds at ease tonight. Let's talk about other personality changes in this MCI group, the mild cognitive impairment: stubbornness, angry outburst, frustration. How does that manifest?
So when somebody has mild cognitive impairment and they're having memory loss, it can be very frustrating, right? It can be very frustrating, particularly if it's worse than just normal aging, and they may try to compensate for it and they can't. So they get impatient, they get angry, they may get angry at themselves, they may take it out on loved ones. They're often very impatient, right? But also those angry outbursts and that irritability, it may be hiding depression, right? Sadness or anxiety that really needs to be recognized and treated by the doctor. And the treatments are oftentimes patients feel so much better once they get treatment.
Some of the other things that you had said that caught our attention is medications that can actually either contribute or cause memory impairment. So you talked about the groups of benzodiazepines. You even said Benadryl.
Yes. So it's always been $1 million question in the last 15 years. Do some of these drugs actually cause dementia or cause Alzheimer's disease? They don't cause it, but they contribute to it. You understand? So particularly sedatives, that's a big one. benzodiazepines, like Xanax or alprazolam or lorazepam, and sleeping medicines such as Ambien, such as Zolpidem. These are not great drugs to use as you get older. Now, these are wonderful drugs, and they're prescribed and they're often helped. But they need to be taken in the short term. This is not something you want to take year in, year out for a long period of time, because they can contribute to this problem. Benadryl is another one. So believe it or not, over-the-counter Benadryl, it's called a anticholinergic medicine, and some people take it for nasal decongestion for sleep. This can help add to cognitive impairment in people over 65.
I don't think people realize that. Isn't that the stuff that's in NyQuil and things like?
Yes,
Okay,
yes.
so another piece of breaking information tonight. Let me take a look at families. Here's a question. Should children get tested if a parent had Alzheimer's? What is genetic? What
Yeah.
do you think I should now go out there and have the blood biomarker?
So that ApoE4, E4, I showed you the slide. It puts you at a much 10 times greater risk for Alzheimer's. Doesn't mean you're going to get it for sure. That's important. We experts do not recommend to get this genetic testing if you're asymptomatic, if you have no symptoms. And the reasoning being is you need to make those lifestyle changes anyway. That's what you need to do. My mother had Alzheimer's. I'm 40 years old. I better start exercising. I better go to the physician and make sure I don't have hypertension, hearing loss, and that I'm eating healthy and I'm doing all the right things for my brain, right? Regardless of whether you have an ApoE4 genome or not. So we don't recommend it unless you start to have symptoms and we want to start the treatment.
Let's get to a couple of other things. A bunch of people have asked about Prevagen. And of course, the commercials are all over the place and on your TV, and they get you all excited that Prevagen is somehow going to work. Is there anything proven?
Sure. So it depends on what you mean by work. And I want to make this clear. There's three things we mean by this. We mean, if I'm having normal, healthy aging, is it going to help me? Is it going to prevent Alzheimer's disease? Or if I have Alzheimer's disease, is it going to fix it? So the last one, no, it's not going to fix. Unfortunately, we don't have a cure for Alzheimer's disease, and that is not going to help you. Is it going to prevent Alzheimer's disease? No, not going to prevent Alzheimer's disease. Can it help with normal aging? There is some evidence that yes, it can help with normal aging. But I need everyone to understand, when you see these things advertised, you're spending money on something that, yeah, maybe it can help you a little bit with cognitive aging, but it's not going to prevent the disease. And I have a saying in my clinic, I want you to add up all the money that you spend on supplements to prevent memory loss and put it into a personal trainer. Think about that, because that's the message I'm trying to get to you, or a gym membership.
And that's what we were going to get to, best practices for nutrition and for lifestyle after the age of 65. But another question came over that caught my attention, and that is anesthesia for surgery, general anesthesia, and putting someone out at the age of over 65, 70. It's not good?
Yeah, I mean, the good news about anesthesia is that anesthesiologists in the last 30 years are getting much better at providing, particularly for older folks, right? And to minimize hypoxia or lack of oxygen to the brain, or keeping people under, and using safer medicines. They're much better at this. But of course, the people that are at greatest risk for the anesthesia are those who already have the cognitive impairment, right? Those are the ones that are at greater risk, or the ones at risk for cognitive impairment. And so you need to talk to your doctor carefully when somebody in your family is having cognitive impairment, before going through with a major procedure, to make sure they're aware of that and what the necessity is for that.
So let's get to the best practices. Tell us what people should be doing after the age of 65, and when you say exercise, does that mean a daily walk? Does that mean a Pilates
So
class?
I'm gonna tell, I say this to every patient, I say this to every family member. Your ability, we all want to live to be 100 years old, but your ability to live well is dependent on your ability to get up out of your seat. That's the truth, right?
Yeah,
And
yeah.
so I know a lot of people over 65 that are pretty healthy, but they're sedentary. And so that you're looking for, you're gonna become infirm. And it's not, it's physical, it's your heart, and it's your brain. So physical activity takes three forms. There's the cardiovascular form. So steps, it's very easy to do. You get a watch, you do your steps, right? 3,000 steps a day, 5,000 steps a day, you can do steps. Number two is strength training, right? That's the second part, build strong bones, right? And the third part is balance, right? So balancing and doing some exercises for full body so that you learn how to balance yourself. Those are the
Why is
key
that so
areas.
important, Dr. Crocco, the balance? And I hear this from people aging. My balance isn't what it used to be. Why is that so critical?
Because as people age, they lose balance. They lose their ability to balance, and they often have a lot of comorbidities or medical problems that can contribute to that. They also may be taking a lot of medications that can contribute to that. So these are all very important factors to healthy aging.
I want you to do a take-home message for us right now to leave us on an up note, on a hopefulness and optimism to say, the future's almost here. We cannot cure Alzheimer's or these dementia-related diseases yet, but we're on the verge, and clinics like yours are on the cusp of doing this. Just give us a couple minutes of
Yeah.
that so the audience can feel good about it.
So rather, as you age, if you're in your 40s, 50s, 60s, 70s, think about the lifestyle changes that you can make to be healthier. It really does make a difference, and it's never too late. That's number one. Number two, and some of the recommendations that I made. Number two, if you feel that your loved one or you yourself really cognitively is struggling and it's not normal and you feel there's something wrong, go to an expert, have them evaluate you, and don't be afraid, because the earlier we know, the more we can help you. Because a lot of times people wait until it's too late, or it's more difficult to treat. And lastly, we do now have treatments and ways to diagnose that are looking better and more promising. They're not perfect. They have side effects, they have problems. It's something you have to talk to the doctor about to see if it's right for you. But we are on the right path, because ultimately with Alzheimer's disease, the proper treatment is going to be multi-pronged approach. It's going to be not just these agents that reduce the amyloid, but it's probably, in my opinion, going to be several different types of treatment all together that hopefully will stop this disease in its tracks.
Do you feel confident that Dr. Crocco, you're going to still be practicing when you say we have a cure for Alzheimer's?
I hope so. Oh my God. I really hope so. I
What-
really hope so. Or, we think of it a lot like HIV. I'm going to leave you with this thought. We have not cured HIV, but we have absolutely stopped it in its track. When I was in medical school 30 years ago, it was a death sentence, HIV. Now, with these amazing medications, different approaches, different medications all together, we can eliminate the virus from people's bodies pretty much, and they live to a ripe old age. So that's kind of the way we're thinking of it. That's how I'm thinking of it.
Alzheimer's and dementias as a chronic disease that's manageable.
Exactly.
Well, we cannot thank you enough for the contributions you make to this field, and the fact that we have this clinic in our own backyard, and we're about to put up the information so that people can get on and see how they can get involved, because our program unfortunately is 1 minute away from coming to an end. Dr. Crocco, thank you from the bottom of our hearts for you being with us tonight, taking your time on a Thursday night to be with us. First of all, thank you.
Oh, thank you so much. And Ileana, thank you as always for
Always
hosting us.
Thank you. It's a privilege. And there you go, everyone. Contact the U Health Psychiatry and Behavioral Sciences, umiamihealth.org/psychiatry. An appointment can be had by calling 305-243-0214. The diseases are just, still stronger than ever. So if you need specific help for you and your family, reach out to them. Thank you again, and complete our survey at the end to give us some feedback. And please, everyone out there, stay well, stay healthy, and happy Thursday night. Good night, Dr. Crocco.
Good night.